Welcome to the last talk in PDF's fifth series of expert briefings. This one's entitled, When Parkinson's Interferes with Gastrointestinal Function. Those of you who've been on these calls before, and I know there are many of you among the 1,175 who register for this session today, know that what we do is try and cover the most important topics in Parkinson's today, and with focus upon specific topics that people in our community have raised with us, where we crowdsource our agendas here, and we try to stay just a little bit off the beaten track of what's new in Parkinson's, though we do that also, and go into things that are of great importance to people that often don't get highlighted in your common or garden educational session, and this is certainly one today, the GI problems in Parkinson's. We're very grateful for the sponsorship of these sessions from two major companies, AbbVie, Inc. and Teva Neuroscience. These companies make the talks possible. It goes without saying that they have no connection with the editorial content, nor do they ask it, and we're very, very grateful to them for their unrestricted support. Please notice that the PowerPoint slide deck that we have can be downloaded from the reminder email that you should have received this morning, or from the PDF webpage. You can tune in to www.pdf.org, www.pdf.org, highlighting this talk, so you can download this from that. If you're a health professional on the call today, note, if you don't already know it, you can earn one free continuing education unit, which is a CEU, through the American Society on Aging, which has kindly partnered with us to give this whole series a professional development component as well as its general educational purpose. If you are registered as a health professional, indicated you would like CEUs, you will receive an email by the end of today with steps on how to collect it. And then you've got 30 days until July 23, to be precise, to collect the CEU, and then we'll receive a certificate in about 45 days after that. Please visit our website. I've mentioned the name, www.pdf.org, if you want to hear more about the PDF Expert Briefing Series, including the program for next year. Next academic year we talk about, which begins in September, and we're putting that together now, but you will see the subjects there as the next few weeks evolve. I'm delighted to say that we have today one of the, I should just say this every time, because it always seems to be true. In this case, really one of the great leaders in the field, Dr. Peter LeWitt. I've had the privilege of knowing him for 15, 16 years now since I came to PDF. And I find him just unremittingly one of the most creative as well as very knowledgeable presences in this field. Creative because he always seems to be asking new questions. I never leave a conversation with him, as I've told him, without one new thought, often several. So we're delighted to have him do this. Dr. LeWitt is known, I'm sure, to many of you on this call. He's professor of neurology at Wayne State University, directs the Parkinson's Disease and Movement Disorder Program at Henry Ford Hospital. He has many research interests. They include neuroprotection and the pharmacological management of Parkinson's disease. Something that he told me before the session opened is something that he wants to strengthen in the professional management and professional education of our field. He's been active in clinical trials of new medications for Parkinson's and Alzheimer's for many years. And in that capacity, he's been a very active leader of the Parkinson Study Group, which all of you know, I think certainly most of you know, is the preeminent consortium of clinical research in the world, and certainly in North America. He also works at the National Institutes of Health, and really many other things I won't have time to go through today. He's worked with the National Parkinson Foundation, our colleague organization based in Florida, and also with Michael J. Fox Foundation. He's a man for all seasons and for all purposes, and we're just absolutely thrilled that he could join us today to present this talk on the all-important matter of GI problems in Parkinson's disease. Dr. LeWitt.
Well, Robin, thank you. You can't get a more gracious introduction than from Robert Elliot, who's provided so much leadership and service to the Parkinson community and has been a good friend for probably even more years than that. Appreciate the opportunity to speak to you this afternoon or wherever in the world and whatever time zone you're in about this important part of our bodies that has to do with so much having how Parkinson's disease can affect one's health, one's function of medications, and indeed might be opening our eyes to even causation of the disease. So I put up the objectives of our talk this hour to go over how Parkinson's disease might affect the average individual and to talk about some strategies that you can use for making medications work better, and possibly we might even have some insights from feedback as to what you out there have discovered. Your questions, your comments to be emailed in are an important part of this session. I look forward to hearing and learning from you. So these are the objectives, practical issues, as well as some of the research will be talked about, and I'll go over some of the medication approaches, but I keep in mind that Parkinson's is more than pills. So let's take a look back to almost 200 years ago. James Parkinson, a London physician, wrote the essay on the shaking palsy, which put Parkinson's disease in the lexicon of at least Western medicine. The Egyptian papyrus scrolls and ancient Chinese medicine, of course, made mention of this disorder, but it was only about 200 years ago that we know this disorder in its modern form. And James Parkinson recognized constipation and other problems of a slow GI tract as some of the earliest features in print describing this disorder. Today, we recognize a list of items on this slide: disordered salivation, sometimes manifesting as drooling, swallowing difficulty, for which the medical term is dysphagia, gastric paresis, another medical jargon meaning merely decreased or slowed emptying function of the stomach, constipation, that problem of decreased bowel movement frequency, and defecatory difficulty, sometimes it goes hand in hand, as it were, with constipation. So these are the main things that go wrong with the GI tract in Parkinson's disease, and there may be a reason for this because there's increasing evidence, as I'll talk about in a little while, that the changes in the brain that cause the slowness of movement and the tremors and the rigidity of muscles may also simultaneously be affecting nerve cells that run the lower GI tract. In fact, as we'll see, the disorder might even begin there and travel up north to the brain as we learn more about what might be causing Parkinson's and what its very earliest stages in the body are, perhaps even before the symptoms emerge. So this is just an overview. I want to spend a little bit of time talking about problems like drooling because we have treatments available, ways to decrease excessive salivation, ways to diminish the problems of saliva leaving the mouth and ending up on clothing. I think the most promising directions are ways that botulinum toxin can be used, injected into salivary glands to lessen the tendency for the salivary glands in the front of the mouth to cause drooling. There is a study ongoing investigating one of the several botulinum products out there, and around the world, Botox and Dysport and Xeomin, products that are on the market, as well as a drug called Myoblock, in Europe it has a different name, Neurology, are all available for dealing with excessive salivation and drooling if nothing else works. But sometimes it's as simple as chewing gum or just positioning your chair to tilt back slightly to change the effects of gravitation to keep oral secretions from coming out of the mouth in the front and going back down the throat. The real problem in Parkinson's, as best we understand it, is not excessive activity of the salivary glands, but rather the lack of regular swallowing. Most people swallow a few times per minute, and if you don't keep up that rate, the rate of production of saliva can essentially lead to overfilling the cistern there, and it can come out from the mouth. Second on this list is a disordered problem of swallowing, and dysphagia has many different aspects to it. The use of the tongue to push food and fluids back into the upper throat, the contraction of muscles in the top of the throat, and so on. These are things I'm going to go over as we come up with a diagram, but suffice it to say, not all swallowing difficulty in a person who happens to have Parkinson's is necessarily due to this disorder. There are other factors that can interfere with swallowing, and putting this question to your physician or to a speech and swallowing therapist is often important because you don't want to overlook other treatable conditions that mimic the problems of Parkinson's disease. And gastric paresis we'll talk about in a moment as we move along here. So first of all, I want to emphasize that there are one or more management strategies ahead for somebody who has these kinds of problems, and sometimes it's the gastrointestinal GI specialist or a speech swallow therapist who needs to be part of the evaluation and the team. Certainly in managing constipation, most neurologists are not as expert or able to carry out the important testing as would be someone in the GI business. Another point to emphasize with constipation is preventing it is a different strategy and a different lifestyle, in a sense, from treating constipation once it's present. Keeping your GI tract from being slowed down, figuring out ways in your diet and with judicious use of medications to keep things moving is an important strategy, and the prevention of constipation ultimately pays off in terms of less discomfort, better absorption of medication, and the ability to lead a more normal life without the kinds of things that constipation imposes. Adequate bowel movement activity is at least 5 to 7 times per week daily, or even more than once daily might be optimal. And oftentimes the strategy for this is the simple glass of water. Increasing your fluid intake is sometimes all it takes to prevent constipation. It certainly isn't the treatment for it when it's present, but increasing one's dietary habits to include more fluids and a high fiber intake and avoiding foods that tend to be constipating is the best strategy there. And so coming up on that last statement there, improving gastrointestinal function can have a positive impact on the consistency of benefit. I want to make a few points about how typical medications work for Parkinson's disease. In taking a drug like levodopa, for example, there is no absorption under the tongue or in the stomach. This is a drug that has to get to the upper part of the small intestine to get absorbed. And the transit from the stomach to the upper GI tract, especially the first 18 inches, is critical for maintaining regularity of drug effect. In fact, the most common problems of advancing Parkinson's disease are really gastrointestinal in nature. The stomach can hold on to pills for excessive periods of time so that a desired dose effect just doesn't happen in a timely fashion. And with constipation, the ability of the upper GI tract to move medication along to churn those contents of the intestine so that optimal absorption occurs just doesn't happen. We know from a lot of experience that taking medication with food slows down and can really stretch out the absorption phase of medication. This can be useful, but in the case of levodopa, if you have a schedule of 3-hour, 4-hour dosing and want to see that drug going to work, absorbing typically within 15 minutes or so, there better not be food digesting in the stomach when that pill comes down the esophagus in order to compete with uptake. The absorption of medication in the small intestine also has some potential competition, not only from the bulk of food, but protein content, and I can explain a little bit how that happens. Proteins in our diet, which are a nutritional component that we all need for good health, is found in meat, in fish, in eggs, in cheeses, milk products, even a number of vegetables have a fair amount of protein content to them. And proteins, when digested, break down to amino acids. Amino acids are just building blocks of life. And levodopa, the key ingredient of Sinemet, is an amino acid also. The upper GI tract is where all amino acids, including levodopa, are absorbed. And in this approximately 18 inches of the small intestine, there is a free-for-all, a competition perhaps between dietary amino acids and levodopa when they all arrive on the scene at the same time. For most people, it isn't all that important whether you have a lot of protein in your diet or whether it's there at breakfast or lunch as well as dinner in a large quantity. But for some individuals, there is a competition that goes on there, and the levodopa, that may be a relatively small component relative to the amount of amino acids from protein, may lose out. In other words, there may not be adequate clinical effect, relief of Parkinson's symptoms, if a lot of protein and the amino acids from that protein are passing through the stomach. In those relatively rare instances where there's a lot of sensitivity to protein in the diet, what can be done is a redistribution of daily protein intake. And usually the strategy is to not have too much protein for breakfast or lunch meals and rather put in that amount that you need every day in the dinner time or even later in the evening. So that's a rare need. I think more is made of this than actually affects the average person. But if there is a lot of irregularity in terms of the effectiveness of levodopa dosing, and this applies only to levodopa, think of the GI tract as a possible participant in that and investigate that with your physician as to whether the spacing of medication, taking it a half hour before, an hour after a meal, or doing the experiment of restricting protein and seeing if that makes a difference. That can be an important step towards lessening the fluctuations of levodopa effect. Another thing that just comes from empirical observation, and I don't think it's been studied adequately, is just that constipation on a regular basis seems to contribute to irregularity in the absorption of levodopa. And this is a problem that many patients notice in the reverse. That is, when constipation is adequately treated or prevented, that all of a sudden there's much more regularity of medication effect. So that's worth keeping in mind to see if that works for those of you out there who are affected. There are a couple of other interesting aspects of Parkinson's and the GI tract that I want to get into before we get to the questions. Let's talk about, first of all, how often problems of constipation and swallowing difficulty occur. And in this slide, I've just highlighted a recent article by colleagues in the Park West study group in Norway who've surveyed mildly affected patients with Parkinson's disease and compared them to healthy age-matched controls to see what the relative incidence of these problems are. And on this list from this publication, you can see I've highlighted constipation as being a symptom that affects 39% of these mildly affected Parkinson patients as compared to an age-matched population of about 14%. In other words, almost 3 times as much complaint of constipation early on in the course of Parkinson's disease. And similarly, the problem of swallowing difficulty, dysphagia, also highlighted here, is, again, about 3 times more common. So these are intrinsic problems to Parkinson's disease. They're occurring perhaps in a mode that might even be there before the very first symptoms of Parkinson's occur. And in this slide from the same report, we can see highlighted that the relative severity of the problem is mostly slight, 92%, and then if you go down the list, an extra 10 complain of mild, and an extra 5 have moderate complaint of constipation. Only 1 has severe. So it's often a mild symptom and perhaps easily overlooked in early stages of Parkinson's, but it's certainly a targeted symptom to improve upon. The swallowing difficulty listed over in the other column on the right side there is something that is absent for 83% of people, and only 22 have slight, and 9 have mild, and 3 complain of moderate swallowing difficulty. So these are not major problems early on in the disorder. It's later on in the course of the condition that it evolves. So let's come to this diagram of the GI system. I just want to make a few points about overall GI function. For one thing, getting food from the mouth region, participants up there being the teeth doing a good job of chopping away at the food, the tongue moving food and liquid back to the mouth, These are functions that, unfortunately, in Parkinson's can be slowed or less precise, and optimizing levodopa intake may be part of ways to improve that. In fact, it's recommended for many patients to take their levodopa or other medication before a meal in order to have the maximum benefit of drug effect during the meal so that the risk for choking or coughing is minimized. The esophagus is that tube between mouth and stomach that has a natural ability to transmit food contents all the way to the stomach. It may be somewhat slowed in Parkinson's disease. There is some evidence for this. But more importantly, it's worth keeping in mind that there are other conditions that can mimic the problem of Parkinson's: decreased diameter of the esophagus, small tumors or other things that obstruct the flow of contents, such as a web across the inside, need to be looked for. And anyone who has coughing, choking, slowed sense of swallowing, a feeling of something sticking in the middle of the throat, should undergo a formal evaluation, because all of these conditions need firm diagnosis that often requires an X-ray test like a barium swallow. I mentioned before that in Parkinson's, the stomach can be delayed in emptying its contents. Cold beverages slow down the emptying of the stomach. Warm beverages can enhance that. So one strategy we recommend to our patients who are having the hang-up of medication effect in their stomach is to take it with a warm beverage. Now, if you don't take levodopa or other medications with liquids at all, that's another factor that can retard the regular uptake by your small intestine of medication. Some people feel that they can swallow a pill without water. Well, that's fine, but it's not going to work all that quickly until some fluids end up on the scene. We have a product in the U.S. which is a form of levodopa that will break apart in the mouth. The tablet is called a dispersible tablet, and it forms sort of a slushy breakdown of the tablet, but it's not absorbing in the mouth. If you put that under your tongue or kept it in your mouth, you're not going to get any effect from that until the contents of that pill are washed down to the stomach where it will absorb. Frankly, I don't see any point for that. No matter how you take the tablet, as long as it gets to the stomach, it's going to absorb. In any case, the hang-up of medication in the stomach is a problem. A product under development in the U.S. and marketed in Europe called Duodopa involves putting a tube through the stomach wall from outside and pumping in a liquid form of levodopa with the tube end past the valve in the stomach that holds back on the emptying of the stomach. So the trick there is a continuous delivery to the upper small intestine without the interrupting function of the stomach, and that's how Duodopa has achieved marked consistency of effect just by improved delivery. We hope in the future there'll be better forms of continuous release levodopa that won't have to involve such a drastic measure like putting a tube through the stomach. But the success of that therapy for those few patients who need it is just one more point of emphasis that the GI tract does have to perform in a consistent, regular manner to deliver drug so that it can get to the brain and relieve the symptoms that are needed. A few other points I want to make about the small intestines and then the large intestines. You can see that there's a lot of tubing down there, but it's the colon, the large intestine, that wraps around the small intestine where many of the problems of Parkinson's occur. Constipation is a problem where the large intestine holds on to contents, extracting fluid as it normally does, and not having enough fluid in the contents coming from the small intestine inward. The only way to overcome that is keep drinking more water, and most GI specialists would recommend at least a liter, that is a quart and a little bit more of fluid per day as a minimum, but perhaps more in warm weather, or if it seems to help for improving control and prevention of constipation. And for those who are using high-fiber supplements, bulk laxatives, those laxatives don't work unless you take the extra fluid with them. They actually become constipating if not taken with increased fluid intake. One problem that I mentioned on the early list is not so much constipation, but what can be called defecatory difficulty. And the muscles that are under control at just the end of the large intestine in the rectum and anus region can sometimes not function as well as they should, and this is sort of a source of blockage, adding to the problems of constipation, or independently seeming like constipation if those muscles are in spasm. This problem requires assessment by a GI specialist. There are a number of things that can mimic that, such as obstructions from tumors. Diverticulosis can also affect that region. Fortunately, there are some treatments that can help for that problem, including selective injection of botulinum toxin or other medications that can help to deal with that problem. So that's why a thorough evaluation of chronic constipation that doesn't respond to the usual remedies is called for. Well, let's pass on to the commonly used treatments for constipation, and I've emphasized before, and I'll emphasize again, keep that fluid intake coming to prevent constipation. It won't treat it when it's there. It helps prevent it. And increasing fiber content with a number of products is often very successful. Diet may not have enough fiber. It's actually quite surprising if you look through a list of foods that have a lot of fiber in them, which ones do and which ones don't. For example, simple salads tend not to have much fiber in them, even though they seem to be rough and crunchy, whereas something like a potato, which is soft and soggy, at least in my plate, is loaded with fiber. So consulting a book on diet or speaking with a dietitian about what is high-fiber food and what is low-fiber is very useful for guiding how to change your meals to increase fiber. But you can supplement any diet that you eat with supplements like psyllium seed or other sources of fiber to keep you going. And listed on the list below here are some non-prescription treatments that can enhance intestinal transit to prevent and even treat constipation. And this includes an old-fashioned remedy, milk of magnesia, which used every third day, every other day, sometimes is perfectly adequate. Perhaps daily intake is more than what's needed, and there is some concern that one can become resistant to its effectiveness if used too frequently. The most commonly used naturally acting laxatives include sorbitol and polyethylene glycol, which goes by the brand name in the U.S. of Miralax. This can be very effective, perhaps more than what some people need, but together with other products that are on the list, such as Ducosate and Ducalax, can be helpful against the occurrence of constipation. And for those who have marked constipation, the term sometimes known as obstipation, magnesium citrate or more aggressive treatments, including therapies with suppositories, can help to deal with episodic constipation. There are also some prescription drugs, as shown in the next slide. These are marketed in North America and may be available elsewhere in the world, and other drugs might be there. These should be prescribed by a GI specialist based on finding that more conventional over-the-counter medications have failed. Each one has potential side effects, but benefits that can merit their use in certain instances. I just wanted to have these names in front of you, as well as the option of going more aggressively against constipation than the matters that were on the previous slide. And now I think I'll shift gears. I've talked about the limits of what I know about constipation. I'm sure a lot of people out there know more about it in living with it or having worked with specialists. But I'll turn to some new dimensions of research that tell us that the GI tract may be an important way station for the development of Parkinson's disease, and it's an area of intense research currently that is pointing to early and possibly even initial findings that the distinctive changes in nerve cells in Parkinson's disease might begin in the colon, not in the brain, but down there in the lower GI tract, which is so affected by the disorder in terms of causing constipation, but it might be more than that. And these findings are governing a lot of thinking as to how the disease might be diagnosed very early on, maybe before any of the motor symptoms are evident, and how the brain disorder might evolve and how we might prevent it in the future. So let's look at some of that evidence. One of the key findings of the past 20 years with Parkinson's disease is that nerve cells appear to be damaged irreversibly by deposition of a protein that goes by the name of alpha-synuclein. And here you see in these pictures of brain cells in somebody who is affected with Parkinson's disease, the brownish staining of these nerve cells with a particular way of imaging alpha-synuclein in the long stretches of nerve cells, which are seen in the upper left-hand box, or to the right of it, box B, where you see that brownish material. Alpha-synuclein gums up nerve cells and is possibly the mechanism why they die. There's a lot of interest in alpha-synuclein-based therapies, ways to prevent its formation as a possible way to slow down the development of Parkinson's disease. And I think that current research is heading towards very promising directions in that manner, including antibodies that are directed against this unwanted protein. Now, it's a naturally occurring protein, but when it aggregates abnormally and forms irreversible clumps within nerve cells, that's when the problem begins. Well, in the next slide, let's take a look at areas of tissue from the colon in somebody with Parkinson's disease. And there they are. The same staining technique was used, demonstrating in several of these slides presence in the walls of the colon, the same abnormal protein aggregations that have been found in the brain throughout just about everybody with Parkinson's. In the lower right-hand corner, again, you see an illustration of the nerve cells of the brain showing the same staining that you see in these other tissues. Well, one of the fascinating things that's come out of recent research is shown in this next slide, work from Kathleen Shannon and colleagues at Rush Presbyterian in Chicago. In their study, they looked at 3 patients in their clinic who had Parkinson's disease and who reported having had routine colonoscopies for general health reasons several years before. And in these 3 examples, 2 years and 3 years before the onset of Parkinson's disease symptoms, colonic biopsies of polyps were taken, and in those biopsies, this is C, D, E, F, G, and H, you can see staining. In other words, before these people had any symptoms of Parkinson's, they had something going on in their colon that was deposition of the same protein that eventually will get to the brain. This is a fascinating story, and other work by other researchers has supported this possibility that perhaps the earliest systemic features of this disorder are to be found in the GI tract. There's also evidence, by the way, that the minor salivary glands in the mouth, skin may also pick up traces of this aggregation. So Parkinson's disease might be a disorder occurring throughout the body, at least in terms of this role of alpha-synuclein aggregation. And this might be an early diagnostic opportunity. Colonoscopies with biopsy might be a way to spot those individuals who have this disorder brewing for them, perhaps years before any brain symptoms occur. And this might be the chance to start a neuroprotective therapy if ever there is one such developed. So I think we have some fascinating insights going on in the laboratories around the world, the opportunity to carry out research evaluating earliest stages of this disorder. And perhaps one of these days we're going to have an answer that involves screening for this disorder years before any symptoms arise. So let's turn to the next slide here. Other things that have been learned about in recent research include that constipation, especially in someone in their 30s or 40s that's otherwise unexplained, may be an early feature of risk for Parkinson's. It's not the case necessarily for everybody, but that together with decreased sense of smell and disturbance of sleep, vivid dreaming, and so on, may be a feature as far as 10 years out before the onset of Parkinson's. So those who are doing biomarker studies and researching long-term outcomes of people with these symptoms may be onto something. In other words, the findings in the colon may be leading to constipation and therefore giving early warning of the eventual development of Parkinson's. Other things that have come out from recent research include evidence that bacterial overgrowth in the small intestine may be a factor that interferes with the uptake of levodopa and other medications. So why some people have such irregular effects of medication, even if they take it right on time, has been sort of a mystery, and there might be a number of different causes, but one of them that's come out from recent research indicates that bacteria in the small intestine might be a factor there. Normally, there aren't too many bacteria growing in that territory of our gut. It's usually down in the large intestine where most bacterial growth occurs. But if things are moving along slowly, it may allow proliferation of bacteria normally present and not necessarily causing any infection, but they may be interfering with the efficiency of levodopa uptake. And another bacterial problem has been of great interest. That is the entity called Helicobacter pylori. That's the name of the bacteria that can survive in the stomach. It's a fascinating story of a bacteria involved in the occurrence of peptic ulcers. It won a group of scientists a Nobel Prize a few years ago. And there is some evidence from researchers in Italy and elsewhere that suggests if you have Helicobacter infection in your stomach, not only are you at risk for peptic ulcer, but it may be associated with decreased good function of the stomach in emptying and therefore leading to fluctuations. Helicobacter pylori infection can be eradicated by an antibiotic regimen. It's a good idea to have it eradicated just for decreasing your risk for stomach ulcers. And at least some evidence out there suggests that it may be a factor in motor fluctuations. There's a simple breathing test for this condition, and your internist or GI specialist can help you out in evaluating for it. And then slowed gastric emptying, there have been a number of medication approaches tested to try and improve that, and although we currently don't have a good medication for everybody, there is some evidence that certain drugs might be able to help against the problems of the stomach, just not participating in a efficient manner to get the drugs into your system. I'm just going to turn to a study that's going on in North America, which has the acronym MOVE-PD. This is an injectable medication that's just undergoing a proof of concept study at several sites across the U.S., carried out by the Parkinson Study Group that has been involved in clinical research for Parkinson's for many years. And I put the contact information for the Parkinson Study Group, which has been involved in a number of clinical trials, and some are planned for the near future as well. And their website is designed for the patient community and their families to take a look at. In this study, which is ongoing, there is active recruiting going on for those who have the problem of chronic constipation, and there would be no charge to participate for those who are candidates. And what's involved is a drug called remamorelin, which is a chemical that shares the properties of ghreolin, which is a naturally occurring small molecule that specifically stimulates receptors at specific sites in the GI tract. And the idea is to improve peristalsis, to move things along better, to enhance muscle contractions and propulsion of contents in the GI tract, doing even better than the naturally occurring substance. So this is, like many drugs, something that mimics a natural function in the hopes of improving upon the natural condition. So I'll say thank you at this point for listening through this. I hope you have some comments, and I hope there has been some useful take-home message for this. Keep asking questions to your physicians. Don't accept the status quo is my advice, and I look forward to hearing from you.
It's Great. Thank you so much, Dr. LeWitt. That was a terrific talk. Much appreciated, and thanks for all the time you've left for questions. We've got a few dozen of them that have come in. We've winnowed down, and if we don't answer all of them, we will try to do it after the call, and so please don't give up. We'll try to get as many as we can done during the session and then follow up later. Most of the questions, I believe, are specific things that you did not cover, and I'm sure some of them had to do with particular experiences with family members and so forth. And so you'll find that most of them quite narrow, but I thought as a whole, very, very good questions and very pertinent to the whole session today. The first one I'd like to take is from the state of Washington, and it picks up on what Dr. LeWitt was saying about the origins around the role of the colon as a geographic entity in the development of Parkinson's. And this person is asking, if that is so, then is it possible that a colonoscopy, tied in perhaps to asking questions that colonoscopies don't always ask, could be a potential early diagnosis technique?
Well, I think, these few cases that I highlighted in the talk might make you think that way. I'm not sure if it's going to be a reliable early diagnostic test, and also not everybody who gets a colonoscopy has a biopsy of tissue made. If someone doesn't have polyps, for example, or any areas of suspicion, the colonoscopy procedure doesn't involve doing a biopsy. But I think it's a very good question. If nothing else comes up in the biomarker research field, and this is proving to be very reliable, and people should be having colonoscopies for preventing colon cancer, among other things, who knows, this might become a diagnostic test. Now, if we ever have the curative treatment for Parkinson's, which needs to be started years in advance, it would certainly be nice to have at least one tissue-based test. Fortunately, it looks like biopsying other tissues, maybe even just a skin biopsy, might also yield useful information. And one area of research that I've been involved in, looking at blood tests that might yield biomarkers, I hope will also become successful at making it even easier than having to have a colonoscopy.
Thank you. This next one is from the state of Michigan. It seems to be, by the way, an alarming number of people from the state of Michigan calling, and not that I would ever suggest, Dr. LeWitt, that your entire patient roster has been...
Hello out there to everybody.
Yeah. But this person wants to know whether a gluten-free diet can help relieve the feeling that this person apparently has of constant bloating in the stomach.
Well, I can't answer, a specific medical question. I don't think specifically for Parkinson's disease that gluten-free intake is needed. Certainly there's some people who are intolerant of gluten in their diet. I think a little bit is too much made that for those who are not gluten intolerant, that reducing gluten intake is of medical importance. But bloating is a feature of gluten intolerance, and so we'll just have to leave it at that if there's better function, not with gluten foods, so much the better.
Thank you. Call from Texas. This person wants to know, how can one best avoid bladder infections that may be or may not be associated with the subject today?
Yeah. Well, bladder infections for men and women have different causes. They sometimes anatomical reasons. They range from things like kidney stones, not drinking enough water, other hygiene-related issues, past history of catheterization or surgery. But it isn't an increased risk in Parkinson's disease, as best I know, and probably is that kind of individual question which should be evaluated by one's physician and possibly looking to a specialist like a urologist.
Of course, and that's a general point, and Dr. LeWitt has mentioned it twice. This obviously is not a clinical session today. People do ask questions that are often concerning their own condition or their family's condition, but we fully understand that this is not a diagnostic visit that you're making, and so any comments you can make about the general topic is always appreciated, but we do also appreciate that people can't get medical information of this kind over the phone. That was just sort of a natural general point that I'm making, and I think it does need to be said. Back to Michigan again. We have a question as to whether glycerin suppositories can be used as a prophylactic, and is there any potential harm, this person is asking, in this particular treatment?
No, I don't think so. And glycerin suppositories might be helpful for the problem of defecatory. In other words, the muscles at the end of the large intestine that are involved in muscle spasm. That's my knowledge as to where their role might play. They don't serve as a laxative, but they do help with the muscle spasm problem. But again, I think it's a very individualized question, and there may be other solutions which worth checking with your gastroenterologist about.
Mm-hmm. Thank you. A call from the state of Florida. This person has apparently found that what she calls pelvic physical therapy can be used for symptoms of constipation and urinary dysfunction. And she wants to know whether you, Dr. LeWitt, has found this useful in your own practice and whether you would recommend it to people who have either of these problems.
Thank you for that comment. No, I'm not familiar with that, and mind you, I'm not a constipation or expert in matters like that, but there has been some study of just general exercise, people who are more mobile and are making an effort to bend and stretch and get out and exercise regularly, and certainly the rate of constipation in such people is less than those who have to be or choose to be sedentary. Whether specific exercises could help, I have more to learn on the topic, I'm afraid.
Thank you. From California, this person is concerned that if he takes over-the-counter anti-acid medications, like, for example, Tums or Rolaids, for stomach issues, is there going to be any danger that the taking of these over-the-counter products could negatively affect either the Parkinson's or the medications he's taking for his Parkinson's?
Well, that's a good question, and I'm not sure I know the exact answer. There has been, however, some study in the past of taking antacids to see if that might help with the emptying of the stomach. In other words, to get more regularity of levodopa effect. And in fact, those studies years ago, and this was just a research study, not a clinical trial, suggested that either foods or antacid tablets might help to increase the exit of levodopa from the stomach, but it wasn't a major effect. And I think the message from that is this would be worth studying someday to see if it had some advantage for some people. So in general, actually, a small amount of food in the stomach, which also acts as a buffer, helps to empty the stomach. If you take a solitary pill with some water and nothing else is happening, a condition in the afternoon called siesta stomach, where your stomach just doesn't seem to be moving anything along, taking a small bite of food, a few crackers, or perhaps a warm beverage can help to trigger the stomach to empty its contents to send the medicine merrily along to where it gets absorbed. Whether an antacid could do that is worth experimenting with for anyone who wants to try it.
That's very helpful. It's clear from reading these questions, Dr. LeWitt, this won't probably surprise you at all, that people with certain symptoms that they think may be unrelated to PD are calling in asking, is this or is that or the other connected with PD? It's very reasonable, I think, because PD is such a busy little devil when it gets around the system, and it creates so many different kinds of problems. Sometimes you think that almost everything people may suffer may somehow be related to it. So here's a couple of examples of this kind, very different examples. A person from South Carolina who is asking whether increased urination at night, maybe as much as 3-4 times at night, could that be connected with either PD meds or PD? And then a second person, I'm not sure where she's from here, is asking about gastroesophageal reflux disease, or GERD, G-E-R-D. Is this a question? So is either GERD or is it increased urination, either of these two things perhaps related to Parkinson's or its medications?
Yeah, I would say probably not, and the reason I can say that is there has been a strong effort at collecting the kinds of problems that people with Parkinson's have to see what other health issues come up. And an example of that is that list in the paper that I showed you of symptoms of all sorts that were reported by mildly affected Parkinson patients off medication at that time compared with age-matched controls. And a few things do stand out. There is an increased tendency towards constipation and swallowing difficulties, as the list showed. But in those same survey, other things that were asked as questions that, for example, with urination and so on, were also questioned and didn't turn out to be problematic. So GERD that is gastroesophageal reflux and urinary problems of various sorts, are just common problems in the population, especially as we get older and wiser. And so I think you gave an important message, Robin, that just because you have Parkinson's doesn't mean that you can't get common garden variety medical problems that need to be looked at elsewhere. I once had a patient who was looking for reassurance that his episodic chest pains were due to Parkinson's, weren't they? And I said, nope, get thee to a doctor. And sure enough, he had problems with his heart that indicated that you can't pin everything on Parkinson's. Parkinson's is bad enough without having to blame for everything that goes wrong with you.
That's a very important general lesson from this talk. Thank you very much. Here are two questions that are kind of related, and they have to do with the opposite to constipation. They have to do, in the one case, with extreme diarrhea, and the second case with something this person calls leakage after a bowel movement in the same area. That is to say, an inability to contain following a bowel movement, and then the extreme diarrhea in the other case, which apparently is a major problem for a person both of whom have been diagnosed with Parkinson's. The question is are there things one can do if that is the problem that might be special to the Parkinson's experience? Any medications or other interventions you would suggest to prevent this?
Well, I can make some general comments. First of all, one thing that comes to mind, a medication that is commonly used for Parkinson's called entacapone or Comtan, and another one called tolcapone or Tasmar. As a side effect of this medication class, for some people, about 5% to be exact, diarrhea can be a known side effect with it, and by stopping the drug, the problem goes away abruptly. So if this is occurring in the context of using entacapone or tolcapone, that could be an explanation. Another problem is people who have episodic constipation, that is, failure of bowel movements for 2 or more days on a regular basis. Sometimes in between those bouts of constipation, will have diarrhea as a consequence of essentially the GI bacterial overgrowth. So the constipation diarrhea scenario may be just related to a challenge to improve control of constipation. Having leakage or other problems there is probably worth an individual question to one's physician and to see if any number of explanations might be there. Certainly chronic diarrhea has a number of causes, including infections with Giardia is one possibility, or C. difficile infections that can be acquired either in the hospital or in other settings, problems of milk intolerance such as lactose intolerance, a number of different causes for diarrhea, and they shouldn't be necessarily pinned down on Parkinson's. But if there is a problem of chronic diarrhea, this often goes along with failure of regular absorption of levodopa.
Thank you very much. I can't resist temptation to insert a question of my own here, Dr. LeWitt. So many of these questions that have been asked are of a very, very senior and respected neurologist who finds himself saying, as you have very appropriately on several occasions now, you need to see somebody else. I guess my question is that I hope it's helpful to the many people on the phone today, is how in the area of GI problems, how much should one expect from one's visit to the neurologist, neurologist in this area? If he's very knowledgeable, as certainly Dr. LeWitt is, obviously you get a lot of the answers. But should this be thought of as a team thing? Should a person with Parkinson's assume that they should at some point find their way also to the GI specialist or any other specialist in connection with these things?
I think so. I think the neurologist who's interested in Parkinson's is usually a team player, that is, realizes that they have a role to decide what is the usual occurrence of a particular symptom. For example, if someone has constipation once a month, I would call that in the normal range of human experience, especially in those over the age of 60, and might counsel somebody that perhaps just increasing the fiber in their diet, drinking water, the advice that I gave earlier seems appropriate. And then if it's a daily occurrence and something that hasn't responded over the counter, the physician has the role of being a triager, that is, encouraging going to the internist, going to a specialist in that field, especially if swallowing difficulties are recognized, which can have some serious implications for choking and could be due to factors, that need to be fixed. For example, stretching the esophagus, especially in men, is a very common need in order to improve quality of swallowing. Very easily done, but if you don't get that person to the testing that is done for this, it's never recognized and just becomes a chronic nuisance of coughing and choking. So I think neurologists, even if they can't take care of these problems themselves, have the opportunity to recognize what's normal aging, let's say, and what needs some fixing.
Thank you very much. We have two questions about Botox, very different ones. First is whether Botox, in your experience, has it been used to alleviate constipation? Is it effective in this regard? And the second, very different one, is there any evidence, also from Michigan, I'm afraid, is there any evidence that Botox in the rectal area has potential to resolve the problem of constipation?
Yes, I think I alluded to this earlier. So botulinum toxin, which is the generic name for Botox, and there are 3 other products, by the way, so it isn't always Botox that's used, can be used for defecatory spasm. That is the muscles right at the end of the small intestine involved in the rectum and anus region. Sometimes relaxing the intensity of contraction of those muscles can be helpful at lessening what to the patient seems like constipation. And so there is a specialized use of botulinum toxin for that reason. This has been established. It isn't experimental at this point and is effective therapy, but it's got to be used appropriately by those who are specialists in that, not neurologists usually.
Thank you. That's and I apologize. Part of my job is supposed to be not to repeat things you've already covered, so I obviously fail in that regard in this last question. I hope you'll all forgive me for that. I think we've come probably to the end of what we can discuss in this session. Here's one from Texas that just came in a couple of minutes ago. Is that we haven't talked so much about dietary stuff. The particular foods that you think a person with Parkinson's with GI problems might be looking at that you'd like to identify for you find helpful in the patients?
Well, that's a good question, and I'm not a nutritionist, but I certainly follow the field with interest. For one thing, it would be nice to know if there are risk factors for getting Parkinson's in the first place, and there have been major efforts at looking around the world as who gets Parkinson's, who doesn't. There was a large-scale study carried out in the Boston area that reported off 15,000 respondents followed for almost 30 years that those who had foods that had red pigments in them, apples, for example, red apples or strawberries, at least 5 times per week, seemed to have a lower risk for Parkinson's by about 40% reduced risk compared to those who didn't have this diet. Now, this was only found in men, not in women. And unfortunately, associations like this don't necessarily say causation. In other words, the person who's eating an apple a day, if that's what it is, may also be doing something else in their life that is the real factor for why their risk is lower. But it's intriguing that diet might have some role. However, other searches have not come up with a particular diet, whether foods containing meats or certain vegetables or antioxidants. There really isn't evidence out there that any particular diet increases your risk for Parkinson's or decreases it. There's no evidence that vitamins help in that regard. We, in this research community, were part of a study of coenzyme Q10, an antioxidant substance. Vitamin E has also been studied, and there was no evidence from these studies that by increasing your antioxidant intake or these particular substances, that the rate of progression of Parkinson's was changed. So the simple message to the community of people with Parkinson's and others is eat healthy, stay away from things that are bad for your heart or high blood pressure, but don't feel that there is something that you have to be taking to lessen the risk for Parkinson's or slow its progression that hasn't been found yet, and there might not be any such substance.
That's such a good general point that I think we're going to just bow out on that one, and thank you very, very much for this terrific talk. I've got a few little business matters which I need to take a couple of minutes on, but that was just wonderful, Dr. LeWitt.
Well, thank you.
And I would want to say to all of our colleagues on the call who did not get their questions answered, I'm afraid I'm sitting here with 20 yellow slips that we couldn't get to, do please call our hotline, where we have a couple of extremely knowledgeable young women working this 8 hours a day, but when they, in the event that they don't have the information, neither of them is an MD, and there are frequent times when this is not shaken out answered directly, but they make it their responsibility to find the answer and get back to people. So please do use that service of ours. We're very happy to offer it. 1-800-457-6676, 1-800-457-6676. You'll get a receptionist here in New York, and she will then refer you to the hotline, and one of the managers of that, actually there's 3 people working on it, and they have a backup MD, and so you'll get, I hope, very good service there. A few other business matters. We encourage you, I always say this because we do use it so much following these sessions, that if you can complete the online survey that should be on your screen right now, is that correct? Is it on the screen? If you can do that, really it's terribly helpful to us. It helps us improve the webinars program and also to select subjects the next time around, which is what's going on right now as we plan for the years 14-15. So please do give us that pleasure and instruction. I'd like to thank our sponsors once more. AbbVie Corporation, used to be Abbott Pharmaceuticals, and it's been known as AbbVie for the last 2 or 3 years. And Teva Neuroscience for the grants they've given us to make the series possible. Much, much appreciated. I should tell you that if you want to see an archive of the event, it'll be up 1 week, exactly 1 week from now, Tuesday, July 1st, at www.pdf.org. My colleague Eli Pollard, who many of you know through her work with the World Parkinson Congress, but she also has several other hats, one of which is working on this with Christiana Evers and others at the PDF headquarters. And she reminds me that you can, in fact, get slides just by tuning into our website and looking for it, and then you can download the slides. And Dr. LeWitt and the others who've given their time to this series kindly allow us to tell you that you can take advantage of that. So we're very grateful to them for that. The next expert briefing series, which I know you all are just in the edges of your seats to hear about, is Tuesday, September 9. We do it always on a Tuesday and always at 1 o'clock Eastern Time, or Eastern Daylight Time, whichever is the season. And this will be on Tuesday, September 9th, on the subject of occupational therapy and Parkinson's, tips for healthy living. And we have 2 authorities in that field, Doctors Linda Tickle-Degnan and Dr. Sue Berger. They'll be presenting on Tuesday, September 9th, so please note your calendars for that. Are there any other public service announcements, Eli? Yes. Oh, I've got to repeat how you get your CEUs. For those of you on the call, maybe several dozen of you who are professionals and wish to get your CEUs, you do it through the American Society on Aging, and what you need to do is to watch for an email that you should receive from us by the end of today, and that will have steps in it as to how you can collect the CEU credit. You have 30 days until July 23rd to collect it, and you'll receive your certificate in 45 days. So for those of you who are health professionals brushing up on their profession, please follow those instructions. Or, of course, you can call here using the number I gave you if you have any follow-up questions to that or anything else you've heard today. So once again, Dr. LeWitt, thank you very much for that terrific talk. Very important, very detailed. I personally learned a lot, and I'm sure many of our colleagues on the call did too. All of you enjoy your summer, and we'll be in touch with you in September, I hope, and hear you back there then. In the meantime, thank you again to Dr. LeWitt, and have a good day. Bye.